Welcome to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Grant Garcia. Dr. Garcia, I'm fired up. I love our guest today. We have a lot in common, but Dr. Garcia, first and foremost, how are you doing?
I'm good. I'm fired up too. You can see we got our backgrounds are stepping it up. We got the next level AI. Even Will changed his background. That's how excited he is for the guests.
I had to step up, man. You and your AI backgrounds have been making me look like a fool. So I was like, man, I'm gonna step up my game. If not, I'm not gonna hear the end of it. But it's good to see you. It's great to have our guests. But as always, let's give a shout out to Mike B and the folks at the Recovery Shop.
So yeah, so big shout out again to them, and they just keep trying to step it up. I mean, the thing is, it's really great for our patients, and actually, I know Dr. Yee uses the recovery shop as well. But patients, I had multiple today saying, "Hey, I like what your surgery is. I like some of the biologic things, but what's the next level I can go to? I really want to get the best outcome." And whether or not always the data is always there for some of these things, the patients really want to know, have an option, and they're going to go aftermarket, or they're going to go through some place that's more reputable if you can have it. So it's really great to have it. They need nutrition, braces, machines, anything you need, and things that we want. It all can be there for them. So it's a really nice option. So thanks again, guys.
100%. And as we get ready to introduce our guest, Dr. Anthony Yee, just a quick background: foot and ankle specialist at the Orthopedic Specialists of Seattle, trained at USC, went to UW, went to Harvard. Eventually, I want to find out what's going on. Where is his allegiance to? Is he a Trojan? Is he a Husky? In fact, maybe we can ask that question now. Let's bring on Dr. Yee. Dr. Yee, welcome back to the show. It's been a while. It's great to see you. And just a little quick background: Dr. Yee performed surgery on my Achilles rupture. So I have a love-hate relationship, because I went to go see Dr. Yee in a very bad state, but he put me all together. Dr. Yee, welcome to the show.
Thanks for having me. Good to see you, Will. Really excited to be here tonight.
That's great. Hey, just let everybody know a little bit about your background. I kind of teased it in the segue, with your background with USC and Harvard and UW, but let everyone else know a little bit about your background and what you do, and really why you specialize in this specific area.
Yeah. So I'm an orthopedic surgeon here in Seattle, Washington, and I subspecialize within orthopedics within foot and ankle. So that's probably about 95% of the care that I provide is with regards to foot and ankle issues. I think the biggest draws to me for foot and ankle were during training, the mentors that I had, some of the most generous, wise folks that I've come across. And then in terms of the actual work itself, the things that really turned me on to foot and ankle were the fact that I get to meet and help patients of all different types of backgrounds, whether it's younger children, young adults, middle-aged folks, older patients. I get to run the whole gambit, and that's I like that, having a little bit of different flavor from each part of different walks of life, different issues, and that keeps me on my toes, so to speak. I like to have that variety. I like to go to the OR and jump from fixing an ankle to repairing an Achilles to replacing an ankle joint to doing something altogether different each step of the way. That's fun for me.
Balance, one thing you really focus on is minimally invasive techniques. Can you kind of go through a little bit more of that in terms of what your focus has been? I mean, I know that a lot of that's new. I mean, I trained doing some foot and ankle at HSS, and we didn't really do a lot of minimally invasive options or get to see them, right? And then in practice, I don't do that. So I'm just curious as to what your focus has been, because that's been a really big deal for foot and ankle, because foot and ankle has always gotten a bad rap about the healing ability of the foot and the ankle, because it's so far away from the heart. So can you kind of go through that and what the benefit is to patients, and what's your thoughts on that?
Absolutely. I think that's one of the things I'm most passionate about is minimally invasive surgery when it comes to foot and ankle. And also, similar to you, I had no exposure to it at all during residency. I didn't even know what it was until fellowship. and learning those techniques and seeing what it does for patients was really eye-opening experience. And I'll be honest, sometimes the first time I saw some of those techniques, I was like, there's no way I'm doing that. That's crazy. But, again, going back to that, humbleness and thirst to always be better and find the best techniques and methods for patients, I think, one of my mentors always said, sort of change the way you ask the question. It says don't ask what you can do through minimally invasive techniques, but what you can't do. But all the while being cognizant of putting patient safety and outcomes first. But I think that it's been a journey so far. It means spending time in the lab, practicing the technique, learning from other people and talking about what works and what doesn't work. But in a nutshell, I think it's the idea behind it is trying to get a really good outcome for your patient, but minimizing that soft tissue injury, keeping the incision small and with all the purpose of less scarring, less pain, less inflammation, and getting the patient back at least a bit of their life back as soon as possible. So for example, with some of the techniques, you would start getting patients weight bearing right away, as opposed to some of the more traditional techniques where we've historically kept them off of entirely for 4 to 6 weeks at a time. And so I think that's been a major game changer, and I think we'll probably see that much more and more in our mainstream as in the coming years.
Awesome. Do you want to bring that up, Will? Can you bring up that bunion correction situation and show the people that? Anthony, you talked about kind of like some wildness you first saw, and then now you were kind of a mainstream. Will you go over this a little bit and kind of describe the situation here?
Yes. So this was exactly what I was talking about earlier. The first time I saw an X-ray of this, there was, I was like, that looks crazy, and I don't know that I'm going to do that. But after seeing time and time again how well patients were doing, fellowship, this is something that I couldn't deny. But basically, I can do all this work to the bunion correction through 4 small incisions, so 4 total stitches. So using a special instrument called a minimally invasive Shannon burr, and relative to some of the other instruments that we use in orthopedics, this spins at a much lower revolution per minute. So the idea being it doesn't generate as much heat, it doesn't damage the soft tissue as much, but when applied correctly due to the design of the burr itself, how it's engineered, you can still, if again used correctly, cut bone. So perform what's called an osteotomy, or a controlled cut of the bone to move and shift and correct the position of, for example, something like a bunion here. So on the left side, you can clearly see this patient had a bunion, which is not necessarily extra bone, but if you look at the right side of that left photo, the long skinny bone in the middle is pointed towards the right side, and so effectively the foot widens, and that area gets quite irritated and rubs. And then if you see on the right hand X-ray, I've made a bony cut, and I've actually shifted the round portion of that long skinny bone, the metatarsal, over to a corrected position that is being held in place with 2 screws. And then there's a little bit of fine tuning of that correction with the bone above it. You see a 3rd screw up there. And I think this has been a game changer. I let patients actually walk out of the surgery center in a flat postoperative shoe immediately after surgery. And I ask them to take it relatively easy. I'm not having them go run laps around immediately, but they get at least a part of their life back pretty quickly with this technique, which has been an awesome experience for me and the patients, more important.
And then will you show that other side, Will? So what kind of was the old way of doing this? I mean, this is obviously pretty new stuff, and it's been really impressive, some of the results.
Yeah. So some of the more traditional, techniques, which I'll use in the right setting. For example, and one popular, especially here in the Northwest, is you'll probably hear as the Lapidus procedure, or there's also
Yep.
Lapiplasty. That's pretty a specific company's instrumentation that's very popular and has been advertised fairly heavily. But with that, it's generally a bigger incision, and you're trying to shift and move bones and fuse them to other bones. And so traditionally, oftentimes, staying off of the foot completely for 6 weeks is, and then, when it comes to surgery around the foot and ankle, that's quite limiting. That's hard. Will knows about staying off of the foot, and that's challenging. Crutches are nobody's friends. You know I've seen all levels of athletes, including professional, struggle on crutches. That's no fun. So I think that's been the major game changer, and that and you can see on that series of X-rays there. So the leftmost side is before surgery. The middle is 6 weeks after surgery. And so looking still a bit crazy there because we're not seeing bony healing quite yet. And then, but you can see how much bone fills in at that 6 month mark. To the point where that's the leftmost screw along that first metatarsal is completely surrounded by with new bone at that point. So, um, all right.
Is there a faster weight bearing with this than the regular
Yeah,
things?
yeah, I'll let them weight bear right away in a flat post-op shoe. So they'll walk out of the surgery center. As long as the bone felt good, there are some caveats. So, if subjective, it is a bit subjective. If I'm worried about the bone quality as I'm putting the screws in, just like when you're putting a screw into a piece of wood, you get a sense of how good that bite of screw is. I might just have them put weight through their heel only, through a special shoe, but still getting them at least part of their life back immediately.
Do you and then from these MIS things, I mean, what other things you really like? I mean, we can show some Syndesmosis, some scope things. What other things that you brought in the last like couple of years are you really excited about from MIS
One
standpoint?
of them actually, Will talked about his Achilles injury, and he was smart about his injury and got medical attention right away. But some people, unfortunately, might not get the diagnosis early on, or right away, or in a timely fashion, and in some cases, that Achilles rupture goes untreated. Whether it's surgical or non-surgical, it's important to really identify it first and have it treated. Then, in those situations, if it goes untreated, unfortunately, that tendon can, heal in a stretched out position. So you see that image on the left. It does a nice job of showing what an Achilles tendon sort of look like. It's never a clean tear. It's like mop ends on both ends that have torn away from each other, and if not properly treated, it'll heal in that stretched out position. So sort of like that rubber band you've used one too many times, uh, you're not gonna be able to generate power through that. And in those situations, the sort of more traditional technique, you make a huge incision along the back of the Achilles, open it up, clean it up, and then maybe do things like a tendon transfer and then get those two tendon ends together in the proper tension. But one of the things that I've come to really enjoy, it's fun, is doing it through a minimally invasive technique. So doing it all arthroscopically. So two small incisions, each needing a single stitch on both sides of the Achilles tendon, and then putting the arthroscope or the camera in there, cleaning it out, and then um, finding the FHL tendon, which is one of the two tendons that helps to bend the big toe down. And then we can actually reroute that and plug it in front of the Achilles tendon all arthroscopically. Which I'll admit the first started doing this, it was incredibly frustrating from a technical standpoint. I was in the lab a bunch practicing this and just trying to figure out how to get it to work properly. But at this point, it's become something that's really fun, and I actually look forward to doing now. It's amazing for for the patient to not have to have this huge incision along the back of their heel, and especially like you were saying earlier, in an area that can be really tough to heal because the blood supply is just not as good as some other parts of the body.
Do you know, is this something? So the viewers have already heard about Achilles, and we can go back to that in a minute from an athlete standpoint. But with this transfer option, are you willing to do it more frequently now that you can do it through the scope, or does that not change your indications for doing this procedure?
Yeah, I think definitely. There are some patients that are higher risk, like you suggested earlier, and I worry a lot less being able to do it through an arthroscopic approach. For example, some patients might have some risk factors that have a higher chance of things like infection, but I sleep a lot easier at night knowing that this can be done through the scope now. And while not all of these injuries require an FHL transfer. I found it interesting. Relatively recently, there was a decent study in Foot and Ankle International where very, very high level soccer players across seas were having their Achilles ruptures treated like this primarily. So instead of repairing the tendon end to end, sort of using that tendon as an internal sort of way to hold the proper tension and to get that Achilles to hold. So it's kind of like splinting it internally. And those patients were able to return to very high levels of soccer, though.
Do you think that's an interesting topic? That's I never heard of that. So they would get the repair of the Achilles, like a lot of these athletes do, and then they would also get the FHL transfer, or they don't repair the Achilles at all.
The latter. So no repair of the Achilles at all, and just using that to set the tension. Not too different, I guess, from the concept of the mid-substance speed bridge. So with the mid-substance speed bridge, as you know, is you're running some suture along the top portion of so when there's two ends, like the top and then the bottom of the rupture, locking in sutures at the top, and then you're bringing it down to meet the bottom end of the rupture.
Like
Yeah,
this one?
exactly. And then you're anchoring it down into the heel bone in that correct tension. You're simply setting the tension, but there's not an end to end repair of the tendon. So just a different way of achieving that.
Yeah.
So,
Okay, I'm sorry.
go well. No,
No,
go.
I was going to say, just kind of bringing some of the sports into this conversation. We saw Dejounte Murray and Jason Tatum. We've seen upticks in the NBA. I believe as of January 2026, we've had 16 Achilles ruptures in the NFL. We've seen Daniel Jones and George Kittle in the playoffs for the 49ers. Is there any reason or trend that's been happening that of why this is going on? Some people are saying, well, maybe these guys are just training less, right? Because they're playing more games, they're not practicing as much. Maybe they're not in, the shape that they used to be when football was doing two a days, or maybe we just don't have the data back then. But is there any correlation, or reason why this is happening, or it's just like, hey, it's just what's happening right now for whatever it is, and we're not exactly sure, but it's something to monitor.
I think we're not entirely sure, but there's some reasonable speculation. I think I think sports science has come a long ways in terms of nutrition and exercise and monitoring minutes and I think we're getting to a point that's much improved and back with data. And that's always good. But I think some of the speculation, um, I think shoe wear has changed a lot. Playing surfaces have changed a lot. And so, um, I think that there's some speculation with regards to both of those two. I don't think anybody can outright prove it. But I think that's where a lot of the conversation is right now, and probably where a lot of the attention will be spent in terms of seeing if there's any correlation. But I think from a nutrition and and strength and um, athletic shape wise, I think the modern athlete is pretty good.
Does it matter that they all have their own personal trainers and everyone's kind of doing their own thing? When you're looking at Christian McCaffrey and the way he's training, and maybe an emphasis more on plyometrics and this, these bursts that he trains pretty much as a track athlete, not as a football player, compared to someone that is just lifting heavy, going hard with certain things. It seems like all of these players have their own trainer, right? LeBron James is famously known for spending millions of dollars on his own trainers. Could that be also something to consider if they're not getting the proper training for their body type, for their age, or anything else that plays along with that?
I think you have a really good point there, and I think it makes it that much harder to study and look at
Mm.
when there's not a standard protocol, and not that there should necessarily be one, but yeah, I think that's a great point. It's hard. I think it's hard to when there's a lot of different variables in the mix. It's certainly hard to say, but I think that you might be onto something there too.
Anthony, can you tell the viewers, like, you deal with an athlete with tendinopathy? Obviously, the acute rupture is pretty obvious, right? That's surgery. It's pretty straightforward. But how do you deal with that spectrum, right? 'Cause it's a little bit harder because we know that occasionally these tendinopathies induced from maybe injections, induced from overtraining, can go on to ruptures. So do you have a threshold ever that you change your management, or how does that work for you with that athlete with the tendinopathy?
Yeah, that's a great question. It's you want these athletes to stay on the field, and then not necessary and do you don't want to we don't want to do unnecessary surgery, but on the flip side, we don't want it to become an urgent issue where an unhealthy tendon that's been stressed constantly suddenly goes and ruptures. We definitely see that happen, unfortunately. And then also in those scenarios, sometimes it can be a more rare variant. That picture that we had up earlier of the what we call the mid-substance Achilles ruptures, where there's a tear along the center of the tendon itself. That's a lot easier to treat, and from a technical standpoint in terms of how we repair that. That's a fairly straightforward surgery overall, that generally doesn't take so long. But there is a rare variant of Achilles tendon sleeve avulsion, rupture, where the tendon tears directly off of the heel bone, and
Mm.
so there's no tendon
No,
attachment.
thank you. No, thank you.
And so in those scenarios, it gets a little more complicated and quite frankly, much more technically challenging to repair that back down onto the heel. And I see that happen, unfortunately, usually in the setting of a patient had chronic or long term pain along the Achilles. They've had this tendinosis they've been struggling with. Um, and yeah, in terms of to more directly answer your question, how do we balance that? I think it just takes regular check-ins and education with regards to what to look out for. We want to stay active, but we don't want to push it to a point where it's really flared up, because that we're probably teetering on the edge of potentially resulting in a rupture. I recently had a patient who was in that situation. She was diligently working through PT, but just had this unhealthy tendon for many, many, many years. And unfortunately, she was doing her stretches at home, and then she had the injury, the sleeve avulsion. So we
Ah,
went and got that taken care of pretty quickly. But yeah, that was one of the cases where it makes you wonder sometimes, when how do we balance it? And I think part of it is just having the education, talking with the patient and having regular check-ins, and um, just going over safe exercises and signs and to look for.
Dr. Yee, can you talk about, I mentioned it to a couple people after I had my Achilles rupture, and how antibiotics, the type of antibiotics,
Mm.
weaken your tendon. Can you explain that to the audience? Because I think a lot of people don't realize that there is a correlation and what specifically that does, and what's the timeline if you're on medication before you ramp up to explosive activity.
Yeah, that's a great question. So we don't entirely understand it, but there is a type of antibiotic that falls under the class of what's called a fluoroquinolone. Yeah, so it can be used for a variety of different infections, including things like upper respiratory tract infections. But there is a black box warning label on it, meaning it's when it's prescribed, basically in huge letters, there's a warning um, that it can cause tendon to weaken, and in some situations, tendon rupture. It's something we always look out for and talk to patients about. Fairly rare, to be honest with you. It's probably one of those things that, I mean, it is certainly we need to talk about with patients, but still pretty rare. I think the percentage of patients who are on that antibiotic who ultimately have a rupture is pretty low, to the point that I would not lose sleep over it, but something to keep an eye out for, especially if you were starting to have some symptoms like pain along a tendon, those types of things. But yeah, that's the black box warning label for those. I have seen one patient who unfortunately was on an antibiotic, that fluoroquinolone antibiotic, and ultimately had a rupture. Um, Got it taken care of, but fortunately, overall, pretty rare.
Do you have a timeline if somebody wanted to be safe that you're on this type of antibiotics? And I don't know if the data shows anywhere to say, well, if you started it last week, you're on for 7 days.
Yeah.
If you're prone to injury, I would be mindful for the next 8 weeks. Or is there something there that you can kind of give some guidance if anyone's wanted to be extra safe, especially for your older weekend warriors that are going out there and being active, but not consistently, where they're a little bit more prone to injury?
I'll be honest with you, I don't know entirely. But my suspicion would be that, that, and I don't have proof for this, but and I'm happy to look this up. But if it's once it's cleared the system, I think that it's probably okay to start easing back into the swing of things. But I think, just thinking about it from a pragmatic standpoint, if you're sick and on an antibiotic, you're probably not going to be running around too soon. So, but once you're recovered, I think it's probably a safe time to get back. So because I would suggest you've completed the antibiotic treatment, and that you've cleared whatever infection you've been dealing with, and it's probably out of your system at that point. Thanks.
Anthony, will you go into, so we've got obviously things that can increase the chances of rupture. How about things that decrease? You talk about biologic therapies, both in for Achilles through tendon ruptures or pre-ruptures, like, so how you deal with the chronic one, and then do you do any biologics ever, or is there any consideration for the future?
Yeah, great question. So for the chronic situations, biologics, like things like PRP, like the platelet-rich plasma, as getting a sample of blood from the arm, putting in that special machine that spins around super fast, and then it layers out the components of the blood, and we can isolate the healing portions and then inject it into specific body parts. That does fairly well. I'm not going to say a grand slam, but fairly well for things like chronic tendinopathy. And I usually reserve that for situations where we've tried the really basic things like the home exercises and some physical therapy. And then if we're not in a good spot, I'll bring that up as an option, because I think it's reasonable at that point for the chronic tendinopathies or tendinosis. And then in terms of the role within like at the time of surgery or at the time of injury wise, probably the biggest application that I use it is for cartilage injuries. And so, like around the ankle joint itself, it's people might have a twist or turn of the ankle, and then we get really honed in on the ligament sprain or the ligament tear, but sometimes we don't pay a much attention as we should to the actual joint itself, where there might be a little pothole or a little divot that's formed where the cartilage was. And so, kind of like when you drive a car over the pothole, that can be uncomfortable in the ankle joint, and sometimes that can feel unstable. And over time, the rest of the road might start to crumble a bit, meaning the rest of the joint. And in these situations, oftentimes when I'm treating these types of cartilage injury for the ankle itself, unfortunately, we don't have, I don't think, as many options as like the knee. I know Dr. Garcia has the amazing um, tool in his toolbox of Macy, for example. That's not FDA approved in the ankle quite yet. Yeah, but what I have in my toolbox is some forms of cartilage repair, kind of like repairing or patching up that pothole in the road. So, filling it in with gravel and then sealing it off. And that gravel might be a little bit of bone graft, and then sealing it off with a substance called biocartilage, or something similar to that, but basically fancy way. It's a extracellular matrix. So basically a scaffolding upon which new collagen can grow. And it's not the exact same type of cartilage that you're born with, but it's a pretty good, reasonable substitute. There's pretty good data showing that it's going to last you 10, 15 years. And, 8 out of 10 people, even at that time point, are doing pretty well. And there's even a recent study that came out where for the foot and ankle was saying that maybe even last 20 years. I'll be honest, I'm a little skeptical of that one, but I think probably 10 to 15 years sounds about right. Um, and then for the biologic portion of it, so I'll generally get some stem cells or PRP, and I'll mix it with that, so sealant, so to speak, the biocartilage, and that's been shown to, right, that can improve results for patients in terms of um, pain relief, and filling in that pothole, so to speak, a little better. And so that's
Do
probably
you
the
do
main.
this arthroscopically or open?
Yeah, I try my best to do it arthroscopically, but if it's in a really challenging, tough spot on the back of the ankle, or I'm not confident that I'm going to be able to do the best job of it just through the scope, I'll make a slightly bigger incision. But generally, my approach is just at least start off arthroscopically, because well, with a little bit of positioning in the ankle and the correct positioning, it's pretty cool where you can reach some far places in the back of the ankle sometimes.
Talking about, I think, arthroscopy, well, like a unit. Will you talk a little bit about how, we talk about, we do do knee scopes, shoulder, elbow, but the ankles, a different animal. There's some other things you can do from the peroneal tendons, et cetera. Will you go into kind of your gamut of arthroscopic options? I mean, it's definitely expanded, I feel like, over the last 5, 10 years.
Yeah, so arthroscopy, yeah, really good tool. Um, so as you know, making small incisions, either front or back of the ankle, you can take a good look around using a small couple millimeter camera or arthroscope, going into the ankle joint and getting a really, really good look at it. Um, some of the ways that I've used it more and more in my practice are, for example, trauma, uh, that you see athletes, breaking their ankles, or having uh, high ankle sprains, or syndesmosis tear. I think the scope is a really useful tool, because it allows us to take a really good direct look at structures such as ligaments that are torn, the rest of the joints, and then also gives us the ability to do something called like a dynamic evaluation. So in real life, I can move the fibula bone, and right here, for example, I'm putting an instrument called a shaver on. So if this is someone's left ankle, as if they're laying down on a table, and so I'm putting this instrument in from the front of the ankle. And so to the left of this picture is the shin bone, the bottom is the talus, and to the right is the fibula bone. And so those three bones are the main bones that come together to make your ankle joint. And with a high ankle sprain, the ligaments that connect, you can think about them like ropes connecting two bones, connecting the fibula and the tibia, so the shin bone and that side skinny bone on the little toe side of your ankle, those tear. And if I press on this bone from front to back or side to side, sometimes I can see that fibula shifting and the tibia staying still. And so that's a nice sort of dynamic way to evaluate, not only is the ligament torn, but is it also unstable? Because there are a lot of things that can tear but are not unstable that we don't necessarily have to repair or address through surgery, and our bodies can do a reasonable job of repairing. But this has been a nice way, really nice way to evaluate, and without causing significant trauma. There are ways to make a big incision and look directly at the syndesmosis or the relationship between the tibia and fibula. But this is a really nice way of doing it, to be really small, in a minimally invasive fashion.
Do you do you think this is something? Is this something that you've already made the decision to do it, or this sometimes helps you make your decision on what to do?
A little bit of both. I think most of the time I'll probably go in there, if I'm suspicious enough based on their pattern of injury that they've also had a high ankle sprain on top of everything else. I'll talk to them about the pros and cons of just going ahead and doing the scope to begin with. But sometimes, if you're on the edge or not entirely sure, that can be a nice tool as well to help you decide what you need to do.
Uh, I want to come back to the high ankle sprain because that's a really common thing. We see it a lot in sports. I know Will, I'm sure Will has tons of players off the top of his head he can think of that he's had to seen them before. But this ankle fracture idea, obviously, we're both Giants fans. So Cam Scatterby getting the ankle fracture. Do you think, like, how has the role of this ankle scope evolved? 'Cause I know you started doing those at our practice. That was pretty cool because I had not seen that as well in my training. Um, what percentage now are you doing ankle scopes with the ORIF or the fixation of the ankle?
Yeah. So any higher energy ankle fracture, and I'll define that a little better, but I'm scoping. And, and the rationale is that higher the energy, there's going to be almost certainly something in the joint that's going on, whether it's a loose piece of bone, loose piece of cartilage, or like an osteochondral injury, so like a divot in the cartilage slash bone. High percentage, I'd say, have an injury like that. And the high energies that I consider are, if there was a dislocation, I am for sure doing that because it's almost
Okay.
certain that there's something that's happened. Or there are, the three sides to the ankle. So they're like bimalleolar ankle fracture, be two sides that are broken. Trimalleolar would be three. Any trimalleolar or all three sides are broken, that generally suggests a higher mechanism of injury as well. And I'll put a scope in that ankle as well. And then also other things, if there are clear evidence of ligamentous injury that looks unstable, for example, let's say there's a fibula fracture plus the syndesmosis looks awfully wide, that tells me as well that a lot of energy went through that ankle. So I'll put the scope in there as well.
Do you think so? But when you put the scope in, so that's good for the listeners. Obviously, they're going to get an ankle ORIF for somebody and they don't get the scope, which obviously is not something that, if I'm on call and doing ankle fracture, I probably don't feel as comfortable scoping the ankle if I haven't done that many. Is that a reason to consider someone like you as a specialist to do it? Like, what is the benefit of having the scope?
Yeah.
You can treat it there, or is it just information?
I'd say both. If there's an injury there, you can treat it. I never don't want to leave anything loose in the ankle joint because that can cause problems later down the road. So addressing it then and there. And then if there is a talus injury, you can also consider treating it. But I have a conversation before with the patient with regards to the pros and cons with that, before going in, so that we're ready to go if I do notice that. But I think, at a minimum, it also gives us information about sort of what you can expect into the future. So I think, the best case scenario, I say, hey, your ankle actually looked great. It looked clean. I'm not too worried about the cartilage. It actually looked really nice in there. So I'm really optimistic that, we're hopefully not going to have to deal with much in the way of arthritis down the road or wear and tear of the ankle joint. And then, and then let's say that there is a cartilage injury, then I could say, hey, we'll have to, unfortunately see how the ankle does. There was a pretty big cartilage injury there. I cleaned it up, I treated it, but all history suggests that your ankle might wear out faster than we hold for, and if that time comes, we can talk about treatment options. But I think good for the patient to have in the back of their head, so they know, they can sort of plan their life accordingly, and keep that in mind moving forward.
I think my
I think that's a
ankle
good point.
calf
Sorry.
is, no, I was just gonna say, I think my ankle and calf is tightened up since we've had this conversation. I'm feeling every little nook and cranny. With all the evaluation and all the conversations of Achilles and dislocations and everything else. I just want to throw it out there. I'm checking myself here, but all jokes
He
aside,
might be undergoing a scope soon. Who knows? He
yeah,
has to get his
I'm
evaluation.
going in. I'm gonna make an office appointment right now. Just have to check everything out. For Cam that had this injury, we saw Fred Warner had this injury. He looked like he was ready to come back for the playoffs. Just amazingly freak athletes. But when you're evaluating somebody with such a serious injury, what are the steps to not only get back to everyday normal, but performance normal? And where do you go? Hey, thumbs up, you're clear. And what's that process look like
Yeah,
with that type of injury?
I think at time zero, making sure you don't miss any other injuries. So,
Mm,
you see the big obvious one in front of you, but always take the time, as a provider, to check them from head to toe, make sure there's nothing else going on. So the last thing we want is we fix
miss.
fix the obvious issue, but there's something else lingering that causes problems down the road. And then the next part, I think, is coming up with a thoughtful plan on how to best tackle it. Managing the soft tissue portion of it. So one of my mentors always said, a fracture is only um, injury beneath a bigger soft tissue injury. So making sure that we're not missing something else there as well, and we're handling that with care so the patient recovers well. And then thoughtful surgical planning. If you're concerned that you're not, or if something looks off and you're not quite convinced that this is looking straightforward, don't be afraid to get more imaging. Sometimes things like a CT scan can really open your eyes to things that you might have otherwise missed. X-rays are a good screening tool, but don't show the full picture. And then I think game planning for the OR, having a plan A, B, and C, and having those backups available to you. Um, you know, just like a game plan going into a game doesn't always, they're not always going with game plan A. But having plan B may not be bad, plan C might not be bad, but having those options to make sure, for example, like instrumentation, or you may be set on using a certain implant, but being aware that maybe that doesn't work out, you have to use something else to get the job done. And then just not leaving the operating room until you're completely happy with how everything is looking. And so just really taking your time, and knowing that maybe even if you had to redo a step, that might add 10 minutes, but that may be the difference between getting this thing perfect and not. And just being humble enough to acknowledge that.
This is
Uh,
what every patient wants to hear, by the way. I mean, every patient that comes in wants to hear that from their doctor. I'm going to go in, I'm going to check it out. It's almost like checking the list, checking it twice, seeing if you're naughty or nice. And that's what you're doing. You're being extra nice by doing all that stuff. So, as a patient that's hearing what you're saying, that's exactly what I want to hear. You're going in, you're doing the job, but you're checking everything and making sure that when you're done, if you're happy, then I know most likely the patient's going to be happy. So, I just wanted to say that.
Yeah, absolutely. I completely agree. I've actually written down a list with if the case is getting really complicated, and I say, hey, can someone check that box right there?
Mm.
And as we're going through, just to make sure, you can never be too careful. And then and I think on the other side of surgery, I think the rehab is super important. So making sure you've got a good team, and folks that you trust, like good. I think we're lucky here in Seattle. We have some awesome physical therapists all throughout that do a really nice job, One of the things I most appreciate is the communication sort of back and forth, whether it's a text or a quick call or an email saying, hey, so and so is doing great, or hey, what do you think we should do at this point? I think that goes a really long way. And to your question, I think that's what makes or breaks, I think, the rehab and getting someone uh, the all the way there, not just halfway there.
So I want to do one more question, then we can start wrapping up because I know that Dr. Yee's got to deal with the monsters that were running around upstairs that we all heard. But anyhow, you got a lot going on, and obviously we want to be careful of your time. So this is a big deal, right? The mental aspect of the surgeries that we do is no joke, right? My regular surgeries, cleanups, things like that, those are pretty quick to get back. But some of these foot and ankle surgeries are not a joke. I mean, you got to see a different Achilles is a different animal, obviously, than an ankle fracture. How do you deal with the athletes and talking about foot and ankle surgery? I mean, most of the surgery you're doing, they're not quick recovery.
Yeah, it's a great question, and Will knows this better than almost anybody. But I just try to have a very real conversation from the first time we meet. So you come into my office with an Achilles rupture, I'm not going to sugarcoat it. I'm just going to plain say, this is going to suck. This is going to test you. It's going to test the people you live with. It's going to
Mhm.
test the people that you love and who are going to be taking care of you. This is probably going to be the hardest injury you recover from, but the good news is that we'll get you there. My goal is that it may not be 100% of what you used to have, but by and large, the average person with this injury is going to get there, is going to be able to do the things that they want to do and they love doing, and so we'll get there. But it's really tough and probably something we don't talk about enough. But I'll say there's a lot of people that get really down and depressed, especially in that first 6 to 12 weeks, when you just feel like everything was taken from you, right? You can't even really walk. And so just the basics, the day-to-day life, are extremely challenging. And so I first I just try to have that conversation, and then you check in to see how they're doing. You know, um, Surprising how many just even small things. I had a patient who came in, and out of all things, he's a great athlete, had an Achilles rupture. Came in, he's like, "Doc, like, you know, my sex drive is just completely gone." And at
Mhm.
first, I was like, "Why is he talking to me about this?" And I realized, it's like this. These are the real life things, right? And then we talk a little further, and we find out, he took the advice of friends and family and saying, "Hey, you need to cut back on calories because you're not working out." And so he was like almost starving himself. And it's so
Which is not
you
good
know
for wound healing. We can go into that another
exactly.
topic.
So just the whole process. So there's a lot to it. I think things we don't always think about, simple things that we don't cover, like nutrition, mental health, all those things, super, super important. But I think just spending a few minutes to make sure that your patient's good and that they have the support, I think can go on.
Yeah,
I,
that's a good point. I just want to jump in real quick. I'll just spend 30 seconds on it. You make an excellent point, and I think that listeners should really focus on that. It's really difficult, and you need to talk to someone. I did get depressed, right? It was hard on my family. Thankfully, I had the nice machine, a little shameless plug for the recovery shop, where my wife could fill in a little bit of water, and I can manage everything from my chair, and she didn't have to run for ice every 20 minutes. So that was really helpful. But carrying the burden of taking care of myself, taking care of the kids, taking care of the household, and dealing with all that, and you're sitting around. So when I went to the doctor, my testosterone levels dropped down because I'm not working out, I'm not being active, and you're feeling a certain way about your manhood, whether it's men or women. But it's really important to realize that it's not just you're healing from the injury, but you're healing from so much physically, mentally, and you need to check yourself. So for anyone out there, we talked about mental health on the show in the past, and you're going through this, talk to someone, whether it's your doctor, your therapist, or anything like that, because that's going to help you get through this. The healing part and the surgery, Dr. Yi took care of that. Eventually, you got to get into physical therapy, because every single doctor that we've talked to says the same thing. I'm going to fix it, but if you don't go to therapy, all my beautiful work that I've done, you just throwing it out the window and you're not doing what you need to do. So just a reminder to our listeners there. Go ahead. Just want to
Yeah.
chime in.
No, it's good. I mean, I think the important part too is you hear that there's doctors that care about the other side of things, right? We talked about the recovery shop. We've talked about the mental aspect. We've had mental health coaches on here. Professional athletes pay a lot of money for a mental health coach.
Mhm.
We talked to the guy that used to do the Seahawks and Russell Wilson, et cetera. Like, there's a mental aspect that's huge, and a lot of us don't have the opportunity to have a coach like that. So you got to find in other ways. But what the really good part is having a surgeon like Dr. Yi, who thinks about those things, and things that are coming to our practice in the future is the nutrition focus, right? Because that's kind of the lost art, is do we do the whole thing? Because as surgeons, we're not good at the like other things. We're really good at like the surgery part. That's what we went to school for. That's what we all the grueling hours were for. But the part that's really important is like, how do we get to the next level? Like, how do we dial up our success? And like you said, it's really important. So anyhow, we could go on and on. This is a whole other show topic. Maybe we'll have Dr. Yi on again to talk about nutrition and how he gets all of his ankles and surgeries back faster. But for now, I think this is probably the end of this nutrition conversation.
Dr. Yi, thank you so much for your time. We really appreciate it. A lot of great learnings, a lot of great information. I hope that our listeners and viewers can really benefit from it. Dr. Anthony Yi with Orthopedic Specialists of Seattle. He's my doctor of choice, so I highly recommend going to talk to him and check him out, because he is on the cutting edge of technology and has a great team to make sure that everyone gets back on their feet. So, Dr. Yi, thank you for your time today.
Hey, thanks for having me. And it's easy to look good when you got good patients like you, Will. So,
Okay, stop it. All right. Say goodbye to Dr. Yi, Dr. Garcia.
Bye.
thanks for having me. Good to see you guys.
That's Dr. Anthony Yi. Just to reiterate, I know we're running out of time here, but it's so important. There's so many key things that he talked about making sure getting it right? Doing the things that he needs to do to make sure that his patient, if he feels good, that stood out for me. If he feels good about the surgery, most likely the patient's going to feel good about the surgery. Talking about doing the rehab, taking care of your mentals. So it's really important. And just like Dr. Yi and all of our other guests, we have transcripts, shows. If you want to be a guest on the show, check us out at sports.talk.com. We're listening on every platform that you can think of. We're on YouTube, wherever we're at Dr. Garcia. We're really happy for Dr. Yi to be on there. Your closing statements as we wrap it up.
Well, again, it's always great to have, Dr. Yi does an amazing job going over everything, and we're able to get a really long gamut, because again, foot and ankle injuries in athletes are huge. We've seen so many of them this year. It's really literally almost as common as some of the knee and sports injuries I deal with, if not more. So it's been great to have an expert on here, and again, more to come, I think, on this. And we have a lot more topics to talk about. But again, if you're interested in being a guest, let us know. We've had a lot of requests, had a lot of guests over the last few months, and we're gonna have some more coming up. And you never know who we're gonna have on, so it changes. We've had F1 drivers or orthopedic surgeons will be coming up soon. We've had really high level cartilage surgeons. We've had people that aren't doctors at different levels. You never know. So thanks again for everyone listening.
Thank you, Dr. Garcia. Appreciate your time as well.